Good afternoon, everyone. Thank you very much to everyone who's joining this call. We're very excited to host this virtual meeting of DSMES providers in Maryland and present up-to-date information about providing services during the COVID-19 national emergency and other information to help strengthen and sustain your programs. My name is Sue Vaith, the Diabetes Coordinator at the Center for Chronic Disease Prevention and Control at the Maryland Department of Health. Next slide, please. Our office is located within the Prevention and Health Promotion Administration at the Maryland Department of Health, and this is our mission and vision. Next slide, please. Before we begin, I'd like to go over some brief housekeeping items. Today's webinar is being recorded and will be made available to you at a later date. Please use the chat box to submit questions. We'll address the questions as they come up. And there will also be an opportunity to address questions at the end as well. For any technical issues that you might be having, please use the chat box function to send a message to Diamond Malhado. And we also ask that all participants give us feedback about this meeting by clicking the evaluation link that will be in the chat box at the end of the webinar. Next slide. Our objectives for today's meeting are to understand the changes CMS has made to ensure diabetes education may continue during the social distancing requirements that have impacted the in-person DSMES classes. Our office has engaged a consultant to assist DSMES providers to strengthen and sustain their programs. Tim McNeil, our consultant, will talk about CMS policy changes regarding telehealth. In addition, he'll discuss additional reimbursable services your organization might be able to implement. And finally, when Tim has finished his presentation, I will talk about a few resources and training events from our office. Next slide. I wanted to have attendees introduce themselves, but we have so much content to cover, and I want to make sure we have time for your questions. So I'm going to hold off on doing that. I'd like to thank our contractors at the Healthcare Dynamics International for hosting this webinar, our contractors. And I will ask, one of the things I will ask you to do, if you are calling in on the phone, could you please add your name in the chat box so that we do know who is on the call? If you're using your computer, we can see who you are, but if you're using a phone, all we can see are parts of your phone number. So would very much appreciate it if you would put your name in the chat box, your first and last names. So now I'd like to introduce our speaker, Timothy McNeil. Mr. McNeil is an independent healthcare consultant specializing in health program development and sustainability. His customers have included the U.S. Department of Health and Human Services, the U.S. Administration on Aging, Administration for Community Living, the National Association of Area Agencies on Aging, and various foundations and national nonprofit organizations. Mr. McNeil is a registered nurse with a bachelor's degree from Howard University and a Master of Public Health from Eastern Virginia Medical School. He is also a U.S. Navy Veteran Nurse Corps officer. I'm very pleased to be able to offer Tim's expertise to our Maryland DSMES providers. Tim, and next slide.
Great, thank you so much, Sue. So we're going to go through, as Sue said, there's quite a bit of content. So at any time, if you want to expound upon any of the information or you want clarification, please put that into the chat, and we'll do our best to address those questions. And then we'll hopefully have time at the end for questions and answers. So we're going to jump right into all of the additional that have been afforded under the public health emergency and the opportunities for DSMES providers. Next slide. So just as a level set, the agenda, we're going to go through the Public Health Emergency Declaration, what that means, the impact on high-risk populations, going to talk about something called Hospital Without Walls and the correlating expanded telehealth. And then lastly, follow that up with chronic care management and MCM as they tie nicely with the DSMES benefit. Next slide. So the public health emergency declaration, so kind of a timeline of things, and this is important. So March 13th, the president signed the national emergency that was related to COVID-19, and the Secretary of Health and Human Services then, subsequent to that, established a public health emergency through the Public Health Service Act. And there's a link to that public health emergency there. And then once that emergency was declared by the Secretary of Health and Human Services, then there were various blanket waivers that were issued as a result. And I'm going to go into a little bit of detail about some of those blanket waivers that were issued, and literally some of these policies are changing on a daily basis. And so much of this is based on the most current update of those waivers that was released April 15th of 2020, and the link to those waivers is listed there. Next slide. So the blanket waivers are retroactive to March 1st, and they will stay in effect through the end of the public health emergency declaration. And there's a broad range of waivers, and if the government decides to pull back on some of those waivers, it likely will not occur until the entire emergency declaration is lifted. And these blanket waivers impact the program, the Medicare and Medicaid programs nationwide, which includes the entire United States, the District of Columbia, and U.S. territories. These waivers provide significant flexibilities to the healthcare system and as it relates to COVID-19 emergency. However, with each of these that I highlight, it's important to note that if a beneficiary doesn't have COVID, is not at risk for COVID, they're not being tested, the waivers do not just apply to those persons. It applies to anyone that needs healthcare services across the board. So it's not limited to people that we think or suspect have COVID. In addition to the payment waivers from CMS, there's also waivers from the Office of Inspector General that waive things such as cost sharing requirements for telehealth visits. Now, these waivers apply to the Medicare and Medicaid program, and they are recommended to also apply to Medicare Advantage plans and Part D prescription plans, but there's not a requirement. But many of those plans are also offering additional flexibilities. Next slide. So this is a select list of some of the applicable blanket waivers that are in place retroactive to March 1st. One is the Emergency Medical Treatment and Labor Act, or EMTALA. So now that allows, so under the current EMTALA regulations, if anyone reports to an emergency room, that emergency room has them on site. But under with this waiver, they can screen people at off-site locations and not run in a violation of EMTALA. So if you've seen on the news where people were being screened at the convention center, or they're being screened across the street from the hospital, that was because this EMTALA waiver was put into place. There's limited discharge planning requirements from hospitals. Many hospitals have moved their discharge planners into one central working location, and they aren't even going up to the units. So the full extent of discharge planning is not occurring. So how does that impact DSMES providers? Well, the COVID emergency did not stop people from getting a new diagnosis of diabetes. It didn't stop people from having heart attacks and all the other things that occur. But what is happening if those people encounter the hospital, they have complications of their disease, there's limited support that's provided to them in the institutional setting, and they're then being discharged without that support. So health systems need to find additional resources to offer to people, because from a discharge planning, case management support that they're getting, that they generally would have been provided in a hospital, is now not always available because of these waivers. There's also the 3-day eligible stay waivers for SNF. The beneficiary co-insurance collection requirement, as I said, if someone provides services to a beneficiary, particularly via telehealth, they do not have to collect the cost sharing requirements. And for the diabetes self-management training benefit, that is that the cost sharing requirement does apply. So Medicare pays 80%, and the beneficiary is responsible for a 20% coinsurance. Or if they have a Medigap plan, that Medigap plan would pay. Because of the public health emergency, a provider that delivers services such as DSMT to a beneficiary, there is no requirement for them to attempt to collect the 20% cost sharing if that beneficiary does not have a Medigap policy. But obviously, if they have a Medigap policy, you should attempt to collect. But this waiver offers flexibility to the provider so that they don't have to collect if there's challenges collecting from the beneficiary. The next applicable waiver is this expansion of telehealth services. And this one's probably been the most interesting one that's rolled out, where now telehealth is offered nationwide or is available nationwide, including in the home of a beneficiary. And there's also a provision that allows providers to operate across state lines, even if they don't have a license in that neighboring state or the state where they're delivering service, and the beneficiary can be in their home. Lastly, and I'll go into this in a little more detail in the telehealth section, the provider that's delivering the service can be in their home, and the beneficiary can be in their respective home, and the services can still be billed just as if it was a face-to-face encounter. And then lastly on this list is the Hospital Without Walls initiative. And I'll give you real local examples in the state of Maryland where hospitals have begun to utilize this Hospital Without Walls waiver to begin preparing for a potential surge of patients. Next slide. So the potential impact of the public health emergency on persons with diabetes. So diabetes self-management providers can begin providing services using these same waivers. So diabetes self-management training can be delivered via telehealth, and they can provide this support to beneficiaries, and those high-risk populations with diabetes are also have a greater risk of mortality as it relates to COVID-19. So this expanded flexibility allows these populations to get more assistance with managing their chronic disease. And as health systems are becoming more and more focused on the COVID population, there's less resources to support the non-COVID population, where their collaboration with community providers to assist beneficiaries is very much important as hospitals prepare for the surge capacity. Next slide. So an example of the impact of this COVID-19 preparation on the US health system, and I'll give a local example next. Next slide. So you may have all seen this, where Governor Hogan activated statewide strike teams for nursing homes. And this was part of the challenge, because if hospitals were beginning to receive COVID patients, and then persons were being admitted to the hospital or transferred from assisted living facilities or nursing homes, some of those facilities refused to take the person back from the hospital for fear that person may have been exposed to COVID in the hospital and may bring COVID back to the facility. And we've all seen in the news what happens when COVID gets into an assisted living facility, a group or congregate living area, or a skilled nursing home or long-term care nursing homes. It can have a substantial impact. And so much so that it caused a crisis where the governor had to activate strike teams that even includes the National Guard to assist nursing homes and hospitals to break up the logjam to facilitate transitions to community. Next slide. So this is directly from the governor's website that outlines what these strike teams are doing and the purpose of these strike teams. And the strike teams are activated in response from nursing homes and local health departments to assist with the management of persons with COVID-19. So the governor is able to call on these strike teams. Strike teams will assist with testing, support on-site screening, and clinical teams and services. So this just really shows how a lot of resources are being put into hospital care, transitions to long-term care settings, but those persons with ongoing chronic disease needs, those things are still happening. So a community partner that can provide expanded diabetes education in support of these beneficiaries that may be in the fray of this COVID national emergency, it could be a significant help. And there's a link at the bottom there to more detail if you want to see what the activity of these strike teams are that the governor has put into place. Next slide. So the potential impact on the hospital. So some hospitals began reporting, as I stated, that they would not accept patients. Nursing home and assisted living facilities would not allow persons to transition back from a hospital unless they had 2 negative COVID-19 tests. Well, just as you all seen, there's a challenge getting tests, and particularly getting 2 tests, and getting the results of the test and coordinating that with the discharge. And it has led to a significant backlog of people who have just general needs not being met. Now, the way that has impacted a local agency, I contacted the Area Agency on Aging in Salisbury and talked with their staff, and I found that they've received, just in the past 2 weeks, 325 new referrals over and above their general call volume for assistance to assist persons that have been discharged from hospitals, to get additional supportive services, shelf-stable meals, health education, coordination, because the access to those services is not what it was before the public health emergency. And so that's just one example of a significant increase in demand. And that's on the Eastern Shore. So think about in the urban areas, how much additional demand and need for this supportive services there likely is. Next slide. So now I'm going to go into detail about what this Hospital Without Walls initiative means. Next slide. So kind of an overview. This Hospital Without Walls CMS is allowing hospitals, healthcare systems to provide services, hospital level services in alternative locations separate from the hospital. And when they do that, they're able to bill those services to the Medicare program just as if the person was admitted to the hospital. So that is significant. Again, and this is not just for hospitals in New York City, not just for hospitals in New Orleans. This is a national model. This is nationally rolled out and applies to all health systems across the country. And so this is pre-surge, this is during the surge, it's anytime a health system decides that they want to begin setting this up, and this authorization is in place, retroactive to March 1st. This Hospital Without Walls initiative also allows ambulatory surgery centers. So, another hot topic is that elective surgeries have all been canceled. Well, many elective surgeries occurred where? At ambulatory surgery centers. So these ambulatory surgery centers in many markets are vacant and idle. So this Hospital Without Walls initiative allows health systems to establish a treatment area in an ambulatory surgery center. And when they admit persons to that ambulatory surgery center, they're able to bill for services just like the person was in a hospital bed in their brick and mortar hospital. Next slide. So this is a listing of some of the areas that CMS, or the alternative locations that CMS stated would be an approved alternative care setting where a hospital that's using this Hospital Without Walls initiative could house patients and bill for those services just like the person was in the hospital. So that includes hotels, convention centers, dormitories such as assisted living facilities and group homes, skilled nursing facilities, even in the home. So CMS held an open door forum on April 9th where the question came up multiple times about what if we, the hospital, would like to admit someone while they're in their home instead of transporting them to our packed hospital. And then we do all the screening and services there. And CMS said, yes, we'll even consider the home as a potential location where a hospital could admit you to your bedroom. You would be in an admission status. The hospital would bill the Medicare program just like you're in a hospital bed, and they could deliver all of the services to you via telehealth, and they'd be reimbursed for the hospital admission and the telehealth services. Next slide. Ambulance transport as well. So there's additional flexibility where EMS doesn't have to transport someone to the emergency department or the hospital for reimbursement. They can transport people to alternative locations, and that can be reimbursed as a EMS transport as well. And there's a listing of some of the alternative transport locations. And this is all retroactive to March 1 and will stay in place for the duration of the public health emergency. Next slide. So all of that to say, what is the opportunity for the diabetes self-management provider? So as hospitals begin expanding these hospital level services into community settings, there is this blanket waiver for telehealth.
Sam, you seem to have gone on mute. Something happened to your sound.
Things such as chronic care management to be done as a non-face-to-face intervention. That dovetails nicely with that, with those services.
We can't hear you.
I think I went out. My internet was unstable. Hopefully everyone can hear me now. Next slide. Yes. So this is a local example. So in Prince George's County, Maryland, the University of Maryland, Prince George's Hospital Center, they began staging additional hospital beds. So Laurel Community Hospital was a hospital that they had closed. They now are opening that up, and then that will be a location, an alternative location where patients could be admitted, and then Prince George's Hospital Center could bill for those persons just as they got it, just as if they were admitted in their regular hospital setting. And so that's a local example where a hospital is taking the hospital without walls flexibility waiver and implementing it in Prince George's County, Maryland. Next slide. So in Washington, D.C. and Baltimore, there's planning to expand the convention centers and make them a potential hospital without walls treatment site. And if persons got admitted to those locations, then the hospital that is affiliated with that would be billing as if that person was admitted to the hospital. Again, just to think, someone's admitted to a non-hospital site and all the resources for the hospital that generally a person will receive, they now no longer will receive. And those persons that may get admitted to these locations, particularly if the hospital's full, they may get admitted for things like complications with their diabetes. And then the hospital is going to need to find a community resource to support this person as they transition them to the community, while the hospital focuses on preparation for COVID patients. So that alignment with a community diabetes self-management training provider that could deliver a range of services to that person after they left, or persons that are potentially at risk and don't want to go to the hospital, it opens up a lot of opportunity to provide additional supports to a population in need while hospitals are for COVID. Next slide. So now I'm going to go into a lot more detail about the expanded telehealth capability under the flexibility waiver. Next slide. So the telehealth waiver is expanded nationwide. It allows telehealth services to be delivered in the home. And in addition to that, CMS expanded the list of telehealth services that are approved. They added another 80 services to the list of approved telehealth services. Prior to the public health emergency, diabetes self-management training and medical nutrition therapy were already on the list, but the expanded services allow for more services to be delivered via a telehealth mechanism, and these services can occur in the beneficiary's home. And this is separate from the Hospital Without Walls initiative, because under the Hospital Without Walls initiative, which also can be delivered via telehealth. But this telehealth expansion is for everybody, hospital or non-hospital patients. So persons in outpatient settings or people that feel that though they have a need, they're being encouraged, don't go to the hospital for your needs, contact your provider, get services in the community so that we can lower the demand on the hospital that is preparing for COVID patients. And so this includes things such as diabetes education is an eligible telehealth service. In the guidance from CMS, it's in a listing of eligible telehealth providers under the expanded waiver. And it included physicians and non-physician practitioners, which non-physician practitioners are physician's assistants and nurse practitioners, psychologists, licensed clinical social workers, registered dietitians, and nutritional professionals. And in many instances, registered dietitians are delivering self-management training, medical nutrition therapy. They are on the designated list of eligible telehealth providers, nurse midwife and clinical nurse specialists. So if you look at this list, one thing that probably or may stand out to you is registered nurses and pharmacists are not on the list. And so that is something that the American Diabetes of Clinical Education Specialists, what used to be called the American Association of Diabetes Educators, they have been in an ongoing dialogue with the Centers for Medicare and Medicaid Services to encourage CMS to expand this eligible list of telehealth providers to include registered nurses and registered pharmacists. And the American Association of Diabetes Educators would like the registered nurses and registered pharmacists to be listed here so they could be an independent provider of things such as, next slide. So the role of registered nurses and pharmacists in this.
And may I interrupt for a moment?
So I mentioned that the American Association of Diabetes Educators or Clinical Education Specialists have submitted a request to CMS to get this rule changed. The status is pending, as noted in the last bullet. So I checked again this morning and they still have not posted that they've gotten a response from CMS. CMS is a little busy now with all of these waivers and changes that they're doing. So they haven't responded to this specific request. And one of the challenges, as I see it, is that currently an independent registered nurse or an individual pharmacist, there's not a mechanism for them to roll as a Medicare provider. There is a pathway for a pharmacy to register as a provider, but not the individual pharmacist. So when implementing these waivers, all of the steps have to be thought through. Is the fact that if CMS expanded the telehealth benefit to include registered nurses, for example, and there has to be a mechanism where a registered nurse can then register to be a Medicare provider, so then they can deliver telehealth services. That is not in place, and so that's the challenge. That is a potential challenge of having a blanket waiver to establish that. Next slide. I think someone's saying in the chat that some of the information is not coming through.
Yes.
Is that still the case?
Some of your audio is going in and out. Would you like to join via phone, Tim?
I can.
Thank you.
Is this any better?
I can hear you clearly now.
You can hear me clearly now? Okay, thank you. So the current CMS policy allows a pharmacy, maybe I should go back to the last slide. Can you go back to the last slide? So the registered nurses and registered pharmacists. So the American Association of Diabetes Educators, or the American Diabetes Clinical Education Specialists, which they're now called, they submitted a request to CMS to modify the list of approved providers, telehealth providers, to include individual pharmacists and registered nurses as independent providers. And that's the status of that is still pending. And I checked this morning, and they still have not posted that there's been a response from CMS about this request. And the next slide, I'm going to go into a little more detail about why they may not have gotten a response. So let's go to that now. Next slide. So there's a Oh, yeah. So the current policy doesn't allow for CMS, or the Medicare administrative contractor that does the enrollment of new providers. There's not a mechanism for registered nurses or an individual pharmacist to register as a provider with the Medicare program, because they're not a recognized provider. So CMS issued a blanket waiver and said, well, as of today, registered nurses can begin delivering telehealth services. There's implications there, but then that means they'd also have to set up a new mechanism for registered nurses to be able to enroll as a provider in the Medicare program. And so there's a lot of other things that would have to be put into place before a registered nurse or registered pharmacist could deliver services if they expanded it. So it's much more than just saying, okay, we're going to just add them to the list. They also would have to change the whole enrollment process for providers. They'd have to educate the MACs, and there's a MACs in every region. The MAC that covers Maryland is Novitas. So they would then have to have a whole new process set up with Novitas so that they then would know how to enroll registered nurses, because there's not a mechanism for that to occur today. So recognizing that factor, I directly contact Novitas, and I posed a question to Novitas and Novitas responded to me on April 16th. So my question was specifically around the fact that there is this expansion of telehealth that includes diabetes self-management training and medical nutrition therapy. And pharmacies, vice the pharmacist, a pharmacy entity can register as a DSMT provider under the Medicare Part B program. And so I wanted to find out from Novitas, did they interpret that rule change from CMS to specifically exclude a registered pharmacy that is delivering service and is approved to deliver DSMT? And Novitas responded to me in writing, stating that all approved DSMES providers can bill for telehealth services to include approved pharmacy entities. And that a pharmacy entity can submit telehealth claims using the specific modifiers, and those would be paid. You may want to verify that with your own by contacting Novitas, the MAC directly. And so you could also get that in writing, and I'd be happy to share the response that I received. But they have an online portal for providers to submit inquiries. It took about 48 hours for me to get my response. And now I have that record saying that a pharmacy that is registered can bill for DSMT services, and those services can be delivered via telehealth under the waiver that allows for those telehealth services to be delivered in the home. There's a question in the chat box about DSMT and MNT being billed for telemedicine in regulated space facilities. And so, yes, The service, DSMT services, MET services can be delivered nationwide space and outside. The challenge there is the rate. The rates change, the rates will be different, as well as how it is billed will be different. But yes, those services can be billed. In fact, there was a CMS webinar where they talked about institutional claims, billing for telehealth, and it's in one of those open door forums where they provided that guidance, as well as CMS said that you could contact your MAC directly, and if you had questions on how to submit those claims, they would also provide you guidance. Next slide.
Hi, Tim. Your audio went out while discussing the facility fees. Do you mind going over that again? I have a few questions in the chat.
Sure. Why don't I do this? I'm going to join directly on my phone. This worked out perfectly during the test, and now it's not working perfectly. I think my internet connection is unstable. But back to the question. There were questions that were posed to CMS about billing for telehealth services that were delivered inside institutional settings and in regulated space. CMS clarified that yes, telehealth services can be delivered in regulated space and in institutional settings, as well as outside of those settings. And we'll go into some more details about how that is coded, but CMS said that yes, that would apply. The challenge is you have to confirm the rate, and you have to closely watch the processing of the claims if you get a rejection, and then quickly follow up with the MAC about why you received the rejection, and then make the adjustments and resubmit. You can also proactively contact the MAC with your questions. CMS did suggest that, so that you can make sure that you're clear, but you can submit claims for telehealth services that are delivered in institutional settings, as well as outside and in the community. Next slide. So this is a listing of the approved telehealth codes that have been approved nationwide, codes that were added to the list. So this is a select list. It definitely is not the entire list, but I wanted to point out some of the codes. So you see things such as health behavior and assessment intervention, medical nutrition therapy, diabetes self-management training. All of these things are now approved telehealth services, including annual wellness visits. So when you look at this list, you see that many of these things aren't necessarily related to management of COVID-19. It is for general management of beneficiaries across the board. This listing of codes is approved nationwide, including in the home, to be delivered via telehealth. Next slide.
Okay, I also have a question that just came in from Gretchen. She asks, are facility fees restricted to RDs?
Is the facility fee restricted to RDs that are delivering the service? Well, the RD is one of the approved providers. Is that question, are you saying if a non-RD delivers that service, then are you able to bill a facility fee? Is that what the question is asking? Because you have to be an approved provider of the telehealth service from the providers that are on the list. Now there is quite a bit of controversy about if a facility bills and applies a facility fee, but a provider that delivers a service is not on that approved list, like an RN. There has been conflicting responses that CMS has provided to that specific question. So I would recommend that you talk to the MAC in a similar manner to the question around pharmacies versus a pharmacist. There were several conflicting answers that came, so I just went directly to the MAC myself, and then I got in writing an answer from the MAC that I then was able to use and have as a permanent record of their response. So if then I were to be audited at a later time, I would be able to show in writing the response from the MAC that said my particular scenario would be approved to bill. So one thing that's important on the slide now is to determine or define what telehealth is. This has also been a point of particular controversy. It requires real-time audio and visual communication between the provider and the beneficiary. So that is like a video chat where I'm able to see you and hear you at the same time, and it's real time. About that were posed to CMS, actually quite a few questions at some of their open door forums about, well, is there a specific level of quality of video and audio? And what if during the time of my communication, as just as happening now, that I lose internet connection or my internet connection is not as good? Does that then disqualify me from billing the service? So there is not a minimum standard where if you don't have broadband, you can't do it. None of that applies. But what does have to happen is that the provider that's billing for the service has to confirm that they did have the ability to conduct real-time audio and visual communication with the beneficiary. If you don't have the ability to have video, then it's not a telehealth service, and it cannot be billed as a telehealth service. So if I just call someone on the phone and we just talk and there's audio only without video, I'm disqualified for billing it as a telehealth benefit. This blanket waiver also, again, just to highlight, allows for the beneficiary to be in the home and receive services or any setting. And there is a waiver from the Office of Inspector General that allows for a provider to use a non-HIPAA compliant technology in order to deliver the telehealth service, as long as they assure that they made their best effort to secure protected health information. And so things that would be unaccepted would be a telehealth encounter using Facebook Live where other Facebook friends could view the interaction. Obviously, that would not be acceptable. So it would still, they'd have to do their best to protect the health information. But if the beneficiary was not able to log into a secure HIPAA compliant portal in order to conduct a telehealth visit, and the best that a beneficiary could do was to engage that person via FaceTime, which FaceTime is generally not HIPAA compliant, then there would not be a potential violation that would be triggered by the Office of Inspector General because the provider used a non-HIPAA compliant means to do telehealth. So that waiver is in place, retroactive to March 1st, and it stays in place for the duration of the public health emergency. Next slide. So this is a select list. It's definitely not an exhaustive list, but it is a select list of available telehealth solutions. I've used a number of these. There's been a lot of controversy as of late about Zoom. A lot of that controversy is around the regular. There is a Zoom for healthcare that is the HIPAA compliant version. It is a service that there's an expense for, and that additional expense is for the HIPAA compliant side of Zoom. So there is a HIPAA compliant Zoom. There's WebEx is one. GoToMeeting has a HIPAA compliant version. The Skype has a HIPAA compliant. So you see there's lots of options there. But with each of those options, if you choose them, you should contact the provider of the technology just to confirm that the version that you have or the version that you attempt to use is a HIPAA compliant version. Now, because of the public health emergency, there is a waiver that from the Office of Inspector General that allows the non-secure methods to be used. Some of those non-secure methods includes FaceTime, Facebook Messenger, WhatsApp, this is popular, Google Hangouts. So these are not necessarily audiovisual telehealth portals, but because of the waiver, a provider can use them if they were not able to use a HIPAA compliant and they assure that they've exhausted all other means that is available. And they would be able to use it without fear of penalty from the Office of Inspector General. Next slide. So the claims filing requirements, so you would bill for telehealth services in the same manner that you would bill for a face-to-face encounter. So that's when an individual and group billing codes would apply. The G0108, that's the individual, and G0109, that's group. If your technology platform is such where it will allow you to have real-time audio, visual, and connection with a group, then you would bill the group codes. For the individual sessions, you would bill the individual codes. And the emergency allows for all services to be rendered as individual DSMT services. So and I'll go into detail about how that occurs, but there's not a requirement where you have to do individual and group for the duration of the public health emergency, because in many areas, on group activities. So CMS has allotted for that by allowing diabetes self-management providers to deliver their entire diabetes self-management education as individual encounters if they're not able to do group. And as you all are likely aware, diabetes self-management training bills in 30-minute increments. Next slide. So the group versus the individual, just a highlight, the standard DSMT benefit is a 10-hour benefit with 1 hour individual and 9 hours of group. And providers can request one-to-one DSMT for the entire duration of the benefit. On the referral order, a provider must indicate COVID-19 risk. That doesn't mean that the beneficiary has COVID-19, but there's a risk if the beneficiary attends groups that the beneficiary could contract COVID-19. So because there's a general risk of COVID-19, the beneficiary can have DSMT as a one-to-one encounter for the entire 10-hour benefit. And telehealth, if indicated, should be listed on the referral. So again, the provider would indicate on the referral COVID-19 risk and telehealth. And if there's no group classes available, the DSMT provider can deliver the service as a one-to-one encounter. If you are already delivering classes, you don't have to go back, the guidance that's been provided, you don't have to go back and obtain new orders and have the provider change the order to put COVID-19 risk and telehealth on the order. You can just document that because of the COVID-19 risk, you're not offering group classes at the time, and you're also not offering in-person classes. And so therefore, you're doing individual one-to-one telehealth services. And then at the completion of that, you would do your standard follow-up with the referring provider. And then you would also detail in your correspondence with the provider that the services were delivered as a one-to-one encounter because group classes were not available. Next slide. So the claims filing. Now this is something that I mentioned earlier, that the policies have been changing almost daily as this emergency has been rolling out. And one of them was exactly what was the guidance on how to file the claims. And this is something that has changed at least 3 times that I know of, maybe more. So the most current guidance from CMS with the link is listed there, that as of April 10th, this is the guidance that's being provided. Where on the rendering provider is listed, you obviously need to list the ICD-10 code, the appropriate code. If you did it all of the services as individual, you would just list individual. If you did group and you had the capacity to deliver telehealth to the group where there was real-time audio and visual connection with all the persons of the group, then obviously you would list the group code that was delivered. And you would bill the code for the service and the place of service equal to what would have occurred if it was furnished in person. So if you would have brought them into your clinic or your pharmacy or in regulated space, you would list that as the place of service, even if the beneficiary was in the home. So let's say I did a telehealth one-to-one DSMT encounter with a beneficiary there in provider, I'm in my home. But if it were not for COVID, I would have done that one-to-one encounter at the clinic location. So because of COVID, we are both in our homes doing the telehealth encounter. On my claim, the place of service would be the clinic, would be my place of service, because that is the location that I would have delivered the service if it were not for the COVID-19 public health emergency. So the place of service is equal to what would have been had the service been furnished in person. That's the most recent guidance. Prior to that, there was guidance that you listed a place of service for telehealth, and that guidance has been rescinded, and now you're supposed to, the guidance that CMS is issuing is that you put the place of service equal to what would have been had the service been furnished in person. In addition to that, you should list the modifier 95, and that modifier indicates that the service was rendered via telehealth. And again, that is the most recent guidance. Next slide. For institutional claims and critical access, there's no change except the modifier is GT. So that's the modifier they would use. There's a question earlier about billing for services that are delivered in institutional settings via telehealth to include DSMT. The modifier would be GT. And again, contact the MAC if you have questions. And as I said, this guidance has changed a few times since March, but this is the most recent guidance on how to get paid. But you should closely monitor your claims, and if the claims get rejected, immediately follow back up with the MAC to get clarification. And if anyone called into your MAC to question a denial, you know the process. You need to have your EIN, your employer identification number, your PTAN, your provider transaction access number, and MPI, as well as the claim information, the beneficiary's Medicare number, the date of service. All of those things you need to have when you call in, and then they can reference that specific claim and give you guidance. Next slide. So some process details. First, you would obviously schedule, and this process details and is recommended process steps to think about when establishing a process to deliver DSMT. So scheduling that appointment, whether that's going to be individual or group. Obviously, if it's individual, then the logistics of that is just scheduling that individual time and the recurring times with that individual, and making sure you have the relevant referral on hand, and the referral has the additional information saying COVID-19 risk and telehealth as the approved mechanism to deliver that service. If it's group, it would be coordinating for the group encounter and then making sure that all of the members of the group are able to log in to that telehealth platform. So you didn't designate, was that service delivered as an individual or a group? When you are delivering that service to the beneficiary, you would code according to the service that was delivered. If I delivered an individual, then I use the individual DSMT code. If I did a group, then I'm using the group code. So there's a question in the chat about if a beneficiary, what happens if a beneficiary does not have video capability and they only have audio capability? Well, they don't meet the requirement for telehealth if they're not able to have both audio and visual. So that is a limiting factor. I can say that part of the CARES Act, which was I think the second version of the COVID-19 stimulus that Congress passed, there was additional money that was set aside. I think it was for $200 million that was applied to FCC to expand the Lifeline program to provide telehealth capability to high-risk populations. But that's not something that's going to solve your problem today, because that's going to take some time. Maybe that may be in place by, if we have a resurgence of COVID in the fall, and then maybe that will help then. But for now, if a beneficiary is not able to access those audio and visual, you cannot bill for a telehealth encounter. You need to document the consent for each individual participant. So if I have a group, then each person in the group needs to consent to participating in your DSMT program via telehealth. And you document that consent. Now, obviously, that can be verbal consent because everything's occurring via a telehealth means, but you do want to have that in place and document that in your clinical notes. You then deliver the DSMT services, and then you would code it appropriately. And just a refresher on the codes, just because that has been something that has changed numerous times. You put the relevant HCPCS code for individual group, the ICD-10 code. The place of service is the location where services would have been rendered if it was done in person, and modifier 95. And please, please, please closely watch for rejections or denials. I was working with a provider, and we had to resubmit the claim 6 times before it finally got approved. And honestly, every time we called the MAC, they had a different recommendation on what should be done. And it was simply a factor in that the rules changes were coming so fast, so furious, that it was difficult for everyone to keep up, including the MAC, and they're only human. So we understood, but we were able to finally get it resolved, but it does take diligence. There's a question in the chat about if the patient is billed the facility fee for DSME, are they responsible for the copay? So the copay, earlier I talked about the fact that there's a waiver that's nationwide waiver from the Office of Inspector General that allows an organization to waive the copay for all telehealth services. And that is in place nationwide. That waiver will stay in place for the duration of the public health emergency. So you do not have to collect the copay if the beneficiary is unable to pay that amount, because there's a waiver in place that allows providers to deliver a telehealth service and not enforce the copayment requirement. There's another question about recording the telehealth meeting. So there's not a requirement to record the telehealth meeting. You do want to document the fact that it was delivered, but you don't have to have a recording of it. If you chose to record it, that's possible, but the challenge is that where you record and store that video needs to be stored in a secure, HIPAA-compliant area and not available and not accessible. And if you're doing multiple telehealth encounters, then that storage capacity becomes a rate limiting factor, being that needs to be secured in a HIPAA-compliant storage facility. So it's not a requirement to record your telehealth encounter. If you wanted to do it, then you need to take into consideration all of the other requirements that go along with storing that video file. Next slide. So the DSMT provider location for telehealth. The provider that's delivering telehealth can be in their home when they're delivering the service. They can be in a clinic setting. They can be anywhere, as long as they're able to protect the health information of the a two-way audio and visual connection with the beneficiary. So that can occur in the home if they were able to deliver that where the provider is in their home or other location. There's no requirement that that DSMT provider be physically located in the approved Medicare location where they're delivering services. And so the example is, I'm a DSMT provider and I have a clinic location, let's say in Prince George's County, and my clinic is registered with Medicare. And Medicare recognizes that as an approved delivery location, and I'm approved. My DSMT program is accredited, and the accrediting organization also recognizes the location of that clinic setting. Now, because of COVID-19, we're not bringing people into our clinic, and I now am going to my house of residence. The beneficiary is at their house, and then we're delivering the service, and I deliver DSMT service. It is not a requirement that because my house is not an approved Medicare provider location that I have to drive into the clinic to deliver the service. So there's a special waiver in place where I'm able to deliver the service as the provider in a non-approved Medicare originating location, and I then connect with the beneficiary wherever the beneficiary may be, as long as the beneficiary consents to receiving the service, and that can be in the beneficiary's home or other location that the beneficiary chooses to receive the service at. Next slide. So some additional miscellaneous items. The reimbursement rate is the same as the allowable amount that would have been paid had that service been rendered in person. The service can be delivered to new or existing patients. So in the past, telehealth services really were limited to existing patients. It can be for new patients, and all the services could occur via telehealth, even if there never had been a face-to-face encounter. And all of this stays in place for the duration of the public health emergency. AADE does, or ADCES does recommend, if anyone is accredited with them, that if you intend to deliver diabetes self-management training services from your home via telehealth, that you add your home as a community site. So they have asked that. That is not something that came from CMS. CMS said that there is no registration requirement for your home address that CMS requires in order to reimburse. All you have to do is put the appropriate modifier, which is 95, to inform CMS that the service was delivered via telehealth. Sometimes I get questioned, well, if I did the service at home or if I did it at the clinic, like how will CMS know? Well, they just want you to say that it was delivered via telehealth. Where you were at when you delivered the telehealth because of the waiver is essentially irrelevant, as long as you delivered it via telehealth and you are confirming that you had real-time audio and visual connection with the beneficiary for the duration of the service that you were delivering. And this telehealth expansion will be for the duration and nationwide. Next slide. Before I go into e-visits, which is a different benefit beyond the diabetes self-management training and medical nutrition therapy that can be delivered by telehealth, I just want to kind of recap first that there's this hospital without walls. So hospitals can deliver services in multiple settings. And there was an expansion of telehealth services that includes diabetes self-management training, medical nutrition therapy, all which can be delivered via telehealth. And those services, now there's a mechanism for those providers to bill and collect. I specifically contacted Novitas, the Medicare administrative contractor that serves Maryland, and confirmed that a pharmacy. Can you hear me now? Am I clear now?
Yes, I can hear you.
Okay, thank you. So those services can be delivered via telehealth by a pharmacy, vice a pharmacist, because there's not a mechanism for a pharmacist to be a registered Medicare provider, but there is a mechanism for a pharmacy, and currently enrolled pharmacies can bill for telehealth per Novitas in the written instruction that they provided to me on the 16th of April. You may want to also get written guidance from Novitas for your own similar situation, so you have that in your records in the event you were audited at a future time. Separate from the expanded benefits, someone asked in the chat that just came across how the process that I went through to contact Novitas. So what I did at Novitas is, if you go to the Novitas webpage, there's a link for providers. You click on that provider link, and then they have an option for you to submit an inquiry. So I submitted a detailed written inquiry in the box that they provided to Novitas. And at the end of that, they ask for my contact information. Now, they're going to ask you for additional information, such as your PTAN, your MPI, and then after you give the PTAN MPI, your name, your contact email, your phone number, then there's a free text field for you to put your question. I typed in the question that I wanted them to respond to. Specifically, it was a pharmacy DSMC provider to bill Part B, and now wishes to deliver telehealth services, and I don't see a pharmacy or pharmacist listed as an approved provider. Am I prohibited from delivering the telehealth service and submitting the claim? And Novitas said no, because you can submit the claim, and as an approved provider, the telehealth benefit is on for all DSMT providers. That includes pharmacies, and so you can deliver that service via telehealth and submit the claim with the appropriate modifier. So I have that in hand, and you could go through that same mechanism. And as I stated, I received my response from Novitas within 48 hours of submitting my inquiry. The next question is about e-visits. So now I'm going to go into the e-visits. I hadn't started that section yet. So the e-visits. So the e-visits are patient-initiated online digital evaluation and management using a patient portal. And so it is a key point is that it is patient-initiated. An e-visit is not the same as a telehealth visit. A telehealth visit does not have to be a patient-initiated online encounter, but an e-visit specifically is a patient-initiated online evaluation and management. And a registered dietitian and nutrition professional is listed as an approved provider to deliver e-visits. Pharmacists and registered nurses are specifically not listed in the approved list of e-visit providers. And there's a physicians and non-physician providers such as nurse practitioners and physician assistants can deliver e-visits. There's a different set of codes for physicians and nurse practitioners. I did not list the physician code, registered dietitian codes, but there's physicians that wish to bill for the e-visits. Please note that this slide, the G codes that are listed, does not apply to you, but there's copious references to the e-visit codes for providers, physicians, nurse practitioners, physicians assistants, so you can get the appropriate code. There's not as much correspondence about the non-physician G codes for e-visits, so that is what's listed here. You see it is a time-based code, and so you see the cumulative time that is provided over a course of time up to 7 days, then you would bill for the appropriate code. Next slide. Next, I'm going to provide some information around the chronic care management benefit. Next slide. So in the 10 national standards for diabetes self-management education and training and supports, there's a standard 8 for ongoing support. So this ongoing support is providing a personalized follow-up plan and ongoing self-managed support to a beneficiary. Well, oftentimes that is done outside of the 10-hour DSMT benefit. And so some organizations are delivering ongoing support, but they don't have a mechanism for reimbursement for that ongoing support. One way that some organizations are delivering expanded support for persons with diabetes over and above the DSMT benefit of 10 hours is enrolling those persons with diabetes into a chronic care management program. And chronic care management then can be delivered as a non-face-to-face, or it can be a face-to-face service that's delivered to a benefit with 2 or more chronic conditions over a calendar month. It's billed based on time, and then each calendar month that those services are delivered, then the provider can bill for that chronic care management service. Now, chronic care management cannot be billed by a registered dietitian, but it can be billed by a physician or non-physician provider. And there is a specific rule change in the Incident 2 rules that allows a physician or non-physician provider to contract with a third-party entity to have clinical staff, to use lease staff, or contractors to deliver that chronic care management service under general supervision of the provider. And the rule change in the Incident 2 rules to allow general supervision may seem like a subtle change, but it actually is a big deal. It's a big, big change. Services had to be delivered under direct supervision, which means that if I'm a provider, say I'm a nurse practitioner, and I then have a registered dietitian or a registered pharmacist that is working with me in the management of care for the beneficiary. And the beneficiary did a detailed comprehensive medication review for this person with diabetes and then set up an ongoing support plan to improve adherence of their medication regimen, for example. And then that beneficiary began to have challenges with medication adherence and then contacted the pharmacist for additional support and guidance outside of the clinical setting. If the direct supervision requirements were in place, then that pharmacist, as they delivered care management services to assist this person with their medication adherence questions, could not bill for those services under the chronic care management provision. So CMS fixed that by changing the Incident 2 rules to specifically state general supervision rules apply in vice direct supervision, which now allows any member of the clinical team to deliver chronic care management services, and they don't have to be in the clinical setting when those services are delivered. And they don't even have to be in the same state, but they do have to be delivering services that are within their defined scope of practice upon which they are delivering the service. So that's the only other caveat. And lastly, they have to be operating, the person that's delivering the chronic care management services has to be within the United States. So it's not something that you could outsource to an offshore entity to deliver those services. They do have to be someone within the United States. But what it does is it provides a pathway for organizations that are delivering diabetes self-management training to contract with the physician group and deliver a DSMT benefit. And they could also enroll those persons into a chronic care management program and then provide additional self-management support outside of the 10-hour benefit. And then that also could be billed on a monthly basis, and the physician can contract with the third-party entity that's delivering this support, and that's a payment mechanism that then can be used to pay for the service. So it would not require the same example that I gave of the pharmacist that is working with the provider to deliver this expanded support, and then that pharmacist is doing these additional service and there's not a payment mechanism. Well, if they're able to expand the chronic care management, there is a payment mechanism, and then there just would need to be a negotiation between the pharmacist and the provider on the rate for those services, and they can use the payment rate for chronic care management as a guide in the negotiation. Next slide.
Tim, this is Sue. I just want to do a time check. There's about 15 minutes left in the webinar.
Oh, thank you. I'm going to speed up because I got a few more things I want to hit and I lost track of time. So the role of evidence-based programs in chronic care management, some of these evidence-based programs really highlight the fact that ongoing support, health coaching, disease self-management that's customized to the beneficiary needs really show an improved outcome overall. So it's not just about the billing. The last slide I talked about a payment mechanism, which is great, but it really also, the evidence shows that this expanded model of delivering services over and above the DSMT benefit also has true clinical implications for long-term improvement. So it's a good thing to do for the patient, and financially it can be sustained long-term through the reimbursement. Next slide. So health coaches can deliver this service. I gave the example of dietitian or a registered dietitian, but some organizations implement health coaches, and those same health coaches could be working in helping to deliver a DSMT class, but then provide expanded health coaching to a beneficiary that can be billed as chronic care management to address other things. A hot topic of discussion that now is even more enhanced because of COVID-19 is addressing social determinants. So you may have seen, like in San Antonio, where there was 3-mile long lines for food. Now just imagine how many of those persons in that line also had diabetes and now don't know how to make selections at the food bank that applies with their diabetes. So now I can provide them with a telehealth encounter to educate them, and I can provide ongoing health coaching under the chronic care management benefit to assist them with addressing their food insecurity so that it aligns with their diabetes management regimen, and that would all be billed and reimbursed to the Medicare program. Next slide. So the eligibility for chronic care management requires that it is a Medicare Part B benefit. The co-insurance or co-payment does apply. The beneficiary has to have 2 or more chronic conditions. Is there a specific type of chronic condition? No, they just have to have 2 or more chronic conditions. What generally goes with diabetes? Diabetes and hypertension, diabetes and depression, diabetes and heart disease. All of those apply as 2 or more chronic conditions, and then the beneficiary would be eligible for chronic care management services, and this would be billed over and above their time receiving diabetes self-management. Next slide. I highlighted the general supervision rules that were incorporated into the Incident 2 that allows for this change that has other persons delivering service under the general supervision of the billing provider and reimbursed. Next slide. The target population. So as this benefit rolled out, there was significant concern that high-risk populations would not have access to chronic care management services. So there is a mandate that the utilization of high-risk populations is reported to Congress and monitored. So there is a process where CMS does monitor the utilization. I can say, based on the CMS guidance that was in the final rules of the provider fee schedule for the 2020 calendar year that was issued back in November of 2019, CMS stated in that guidance that there still is care management benefit, but CMS data shows that there's a significant cost benefit to the Medicare program in reduced total cost of care when chronic care management services are delivered. So they are highly encouraging increased utilization of this benefit to date. Next slide. So this targeting of the population, a lot of groups, they target specific groups and then expand the services. Some of the services that they provide as a chronic care management service outside of the class are things such as medication adherence support, as I described, health coaching, meal preparation support, even identifying meals such as persons with food insecurity and identifying appropriate resources to get assistance. All those things can be billed under the chronic care management benefit. Next slide. So the opportunity, these are the CPT codes for chronic care management. There's a separate code for federally qualified health centers or rural health centers that's listed at the bottom. The rules changed on January 1, 2020 for chronic care management. The benefit was first established in 2015. At that time, there was only one code, and that's the first code that's listed there, 99490 for 20 minutes. The rule change that occurred in January is that every subsequent 20 minutes, up to 1 hour, a provider can bill G2058 for each additional 20 minutes for non-complex chronic care management. And so that has significantly enhanced the level of reimbursement for chronic care management services. There always, since 2017, was a 1 hour benefit, but that was for complex chronic care management. CMS has updated that to allow up to 1 hour for non-complex chronic care management. And then lastly, the FQHC Rural Health Center code G0511, the rate for that code is the average of the non-facility provider codes for all the other providers. But when that allows for federally qualified health centers to deliver chronic care management, and again, the chronic care management is a non-face-to-face service, and even FQHCs can deliver that as a non-face-to-face service and bill for it as a Medicare benefit. And there's a question in the chat, will the slides be made available? Absolutely, the slides will be available. Next slide. So policies that support this model is that the transitional care management and chronic care management services can be delivered to the same beneficiary during the same calendar month. That was also something that was a limiting factor for chronic care management. For organizations that did chronic care management and transitional care management, you knew that you couldn't bill for both of those services during the same calendar month. You can now deliver them at the same time for the same beneficiary, but you cannot double count the time. And the public health emergency now allows for things such as transitional care management to be delivered via telehealth, which is also an initial provider encounter that makes someone eligible for ongoing chronic care management services. Next slide. Medication therapy management. I'm going to try to get through this next slide. So medication therapy management. So medication therapy management is not a Part B Medicare benefit, is a Part D as in dog benefit. And Part D is administered by Part D prescription drug plans. So you generally need to contract with a Part D prescription drug plan in order to be able to be reimbursed for medication therapy management services. One of the reasons I highlight this is because oftentimes persons with diabetes questions and concerns about their medication. And that is also a nice companion with the diabetes self-management training program, where a person then gets an expanded MTM or medication therapy management intervention by a pharmacist. Unfortunately, that's not always reimbursed unless we're able to contract with the Part D plan. Because of the public health emergency, however, there is a pathway where Part D prescription plans have also been encouraged to expand access to new providers because of the public health emergency. So if you have not contacted a Part D plan to discuss that, now would be the time, because they have been highly encouraged to increase their access to services like MTM. And so now we could deliver that service as a companion. The list of eligible clinicians for MTM is listed there. Next slide. So the flexibilities allow prescription drug plans to enhance their enrollment and expedite enrolling new providers. And so that process is in place. It was established by CMS, and each Medicare Advantage plan and Part D plan were encouraged to adopt the same posture. Next slide. So what occurs for MTM services? There's this assessment of health status, a medication treatment plan, a comprehensive medication review is a core part of an MTM service, where you're identifying medication discrepancies, resolving issues, and addressing adverse drug events, and then communicating with all relevant healthcare providers. And as I mentioned, it is a nice companion to a diabetes self-management training program. And I've seen organizations where there is this direct link to MTM services. So then we're really addressing all of the needs of the beneficiary. Next slide. These are the CPT codes for MTM, and they are based on time. So there's a new patient code, established patient code, and then each additional 15 minutes bills 99607, and that is for new or established patients. Next slide. Incident to billing. So I do have work with sites where they delivered an MTM service incident to a clinical visit that was billed as an office visit. So most people are familiar with incident to billing when they get things such as a PPD to test for tuberculosis. You may have gone to your doctor and you never actually saw the doctor. You saw the nurse who placed the PPD, and then you came back and the nurse read the PPD and then signed off on the form and you went on your way. And if you took the time to look at your bill, you would have seen you were billed for an office visit under the billing provider that then provided direct super nurse did the service and it was billed. Well, some organizations use that same approach to bill for MTM services that are delivered incident to the provider. Now, if that person is coming to the clinic to have a office visit anyway, then there's really not a mechanism to do two claims for the same beneficiary on the same day, one being directly with the provider and one being incident to. But it would be relevant if the person came back on a different day, then had their MTM encounter with the pharmacist, and then completed that MTM encounter as incident to the provider, and then that could be billed. So that is another way that some organizations do bill and collect for MTM services, and it becomes a sustainable pathway for those services to be delivered. There does, for incident to services, it does not require a sign off where there's kind of a cosign for the provider. Like see your PPD results. There's not 3 signatures on that. It's usually just the nurse that signed that as an incident to service. It does have to be documented in the clinical record, and there has to be a formal relationship with the entity that provided the MTM service, i.e. the pharmacist and the healthcare provider. Does the healthcare provider, do they have to employ the pharmacist? No, they do not. So they can have an arrangement where that pharmacist is an independent contractor, a leased employee, or they could employ them as a W-2. The service could be delivered incident to and billed. So that is one way. Contracting with the Part D plan and then billing the Part D plan is another mechanism for reimbursement for MTM services. Next slide. So I only have a couple more slides. So steps to engagement. First, I think it's important to assess the local impact. So determine if there's an increased demand for supportive services. Sometimes there's an increase, isn't a major hotspot that's constantly on the news. So I showed where in the University of Maryland Capital Region has shown that they're getting a high increase in critically ill COVID patients in Prince George's County, Maryland. But at the same time, in Salisbury, Maryland, 3-4 hours away, they're seeing an increased demand from patients leaving the hospital that need additional supportive services. And that has led to over 300 calls and requests for additional assistance just in the past 2 weeks. So assessing what is that impact, how does the impact on high-risk populations, persons living in congregate settings with multiple chronic conditions, and sometimes people getting limited discharge planning, there becomes an opportunity for a community provider to step in and fill the void. Next slide. So contacting the local healthcare providers that are planning for these services is essential to define what your potential role would be in delivering the services, what can be delivered via telehealth, identifying barriers to delivering it via telehealth, and then working with the team to address those barriers. Many of these services can be billed and collected, and if they are billed, such as chronic care management, there should be some negotiation in terms of what is the rate that's paid for delivering those services as a contracted third party that's facilitating the delivery of the care. Next slide. So we're almost done. Were there other questions? That's my final slide.
While we're waiting for people to write in the question, I just wanted to, if you can go to the next slide. This is Sue Vaith again. I will just tell everyone that these slides and the recording will be available, as well as a couple of extra resources that we're providing. I'm not going to go through all of these resources that I have on the screen, but there are things that we provide from the Maryland Department of Health, as well as try to call from other sources and send them out to you. One thing I will note is that following today's meeting, you'll receive an invitation to Basecamp. It's a real-time communication tool that can help us share ideas and best practices during this COVID restriction and beyond that. We're going to keep it available throughout, or even after the emergency is done. We can just use it as a communication tool back and forth so you guys could talk back and forth to each other just among Maryland providers, if you think that's going to be useful for you. Finally, I'd like to remind you to click the link for the evaluation that is up in the chat box. It's about oh, thank you, Diamond. She just put it in again. So please take a couple of minutes to give us feedback about this meeting. If we can go to one more slide. For those of you who are thinking about or already providing the National Diabetes Prevention Program, we do provide lifestyle coach training, and we also are providing an online platform for folks who want to use the virtual delivery method. And next slide has my contact information on it, which most of you already have anyway. I will be back in touch with you following this meeting, and I'd like to thank Tim for your expertise and time to go over this. Really important and pertinent, timely information. Would also like to thank everybody on the call for attending. We really appreciate you being here and your questions. If you have other questions, you can send them either directly to Tim with his email, or if you didn't quite get that, you can send them to me, and I will forward them on to Tim so that you can get your questions answered. Thank you all so much for being on the call, and we'll be back in touch.